Yep, that's working fine, Jamie.
Thank you very much. It's great to see people on this webinar, particularly some old friends as well as some hopefully new. So, as Christopher said, my name's Jamie, and I've been working actually on a COVID ward for the last few months, having also done things like tried to set up the Nightingale Hospital in Birmingham. I thought, whilst talking about adverse drug reactions, which was sort of the general title, is I'd use some COVID cases to try and help us understand the importance of adverse drug reactions in clinical practice. But then importantly, of course, it wouldn't be coming from the West Midlands Centre for ADRs, the Regional Yellow Card Centre, without mentioning, of course, reporting and the importance thereof. So I'm very briefly going to go through a bit about prevalence and some definitions, particularly some classification schemes, before going through a couple of cases that are cases from my recent experience, and try and think about the ADRs in their context. On V-Day, as it's been called by some, is that it wouldn't go without mentioning the vaccines, of course, and then briefly towards the end about reporting of ADRs and pharmacovigilance tools. As Christopher said, if you've got any questions, please post them in the chat box. And even if I can't answer them, I hopefully will have some colleagues online that I might even point the finger at to answer the questions. Christopher and Karamjit, our pharmacovigilance pharmacist, included. So I grew up, I suppose, on the 1972 WHO definition of an ADR as a response to a medicinal product which is noxious and unintended and used at doses in man. I also realised that, of course, my slide notes aren't here, so the full definition I almost can't say, but it's been around for a long time. I think it's that noxious, of course, unintended. We never mean to cause harm through drugs. What's been quite interesting, perhaps in the last few years, is the way that the European Medicines Agency have, I suppose, extended the definition to include the use of the products within and outside the terms of marketing authorization. So, for example, through unlicensed or off-label use, or from occupational exposure, and from, for example, overdose. And whilst I think most of us wouldn't class a intentional overdose as an adverse drug reaction, I suppose knowledge of overdose drugs. Are they important? Well, of course, I think they are. It's a major cause of hospital admissions. And if we go back nearly 20 years ago now to work by Munir Pur Mohammed and colleagues up in the northwest of England, they found that 6.5% of consecutive hospital admissions, and they surveyed nearly 20,000 hospital admissions, had an effect from an adverse drug reaction. It, of course, affects quality of life, causing both principally morbidity, but occasionally mortality, and is costly either through, for example, those direct attributable admissions, or, for example, prolonged stay in hospital, or the need to treat adverse drug reactions. And again, per year, perhaps £466 million was extrapolated from that original study. Many are preventable, and certainly, again, in Munir's study, about 2/3 of ADRs in that were thought to be preventable. And unfortunately, of course, still cause several hundred deaths per year in the UK. So the epidemiology is there, and they are important. And the epidemiology is not changing. They remain just as important as ever. Now, I pointed out classifications, and again, people may be very aware of the A and B classifications by Mike Rawlins Thompson that actually looked at this originally, and originally called type A reactions, sometimes augmented reactions, dose-dependent, predictable on the basis of the pharmacology of the drug, and type B or bizarre reactions, idiosyncratic reactions, and perhaps not predictable on the basis of the pharmacology. I'm going to say on the basis of probably the primary pharmacology. It was a few years later that Graham Smith and Aronson from Oxford classified type A as dose-related and type B as non-dose-related. And these are the sort of slides that we typically show to our undergraduates. So type A may be, for example, potentially more common, like I say, related to the pharmacology, usually the on-target effects of the drug at least, and often associated allegedly with low mortality. Things such as the person that's becoming bradycardic because they've got too much digoxin in the system, or they're bradycardic from a beta blocker, or for example, they've had too much opiate or benzodiazepine, hypnotic effects causing some sedation. Type B or bizarre reactions, often not dose related, in fact can be associated with very small doses of the drug, less common and certainly unpredictable, certainly on the basis of the primary pharmacology of the drug, although they may be related, for example, to off-target pharmacological actions, may be associated with high mortality. And penicillin hypersensitivity, of course, that never event in the NHS for a patient to receive penicillin if they're known to have hypersensitivity may cause type 1 hypersensitivity, IgA-mediated reaction, anaphylaxis, and of course there are still, unfortunately, a few cases of death per year from those cases. Other things may be malignant hypothermia or hepatitis. And here we can see a picture actually of the skin sloughing off, and this would be a case of toxic epidermal necrolysis, that sort of Stevens-Johnson's progressive syndrome where it causes very severe skin, and again, associated morbidity and mortality. But particularly actually with Professor Robin Ferner, the Emeritus Professor of Clinical Pharmacology from Birmingham, who's previous director of our centre, he and Jeff Aronson came up with a different classification system, and one that I'm going to use today in a few of the cases, partly because actually it encompasses absolutely every reaction. And so, for example, the A and B reactions have been criticised maybe in a way, or critiqued, because there may be sort of late onset reactions, there may be through cumulative use reactions, and they don't easily fit into the A and B category. Whereas actually, if we look at the DOTS classification system, all reactions can be classified in this way on the basis of the dose of the drug, the time course of the reaction, and the relevant susceptibility factors. And I've got another slide on that. And you can see their original BMJ article for more information. It can also help us to try and think about preventability in practice, particularly when we try and think about, for example, those risk factors for ADRs. So here are some of the susceptibility factors. Again, Professor Ferner and Dr. Aronson have written about this in drug safety, where we can see, for example, GAST is a good acronym to try and remember some of the susceptibility factors, such as genetic factors, age factors, sex factors, physiological state, exogenous drugs, or indeed foods, which of course increasingly thought to be important as we recognise the potential kinetic interactions of certain foodstuffs, and disease. And again, all of the examples are there on the slide. I won't read them out for the sake of time. So I want to take you through a couple of case studies. The first one is a case of Mr. EP, an 82-year-old Caucasian man who was originally admitted to the Queen Elizabeth Hospital here in Birmingham with confusion. Now, he'd had long-term shortness of breath, he'd had asthma, COPD overlap syndrome through chronic smoking, but it had got worse over the previous 4 days. He was susceptible to taking lots of alcohol, particularly during lockdown, where he hadn't been able to see his family. And he also had a history of ischemic cardiac disease with both acute coronary syndromes and myocardial infarction, previous stents in his heart, and had a permanent pacemaker inserted. He was on the list of drugs we could see here, so statin, platelet, various inhalers, including beclometasone, formoterol, Foster, tiotropium as a long-acting muscarinic agonist, salbutamol and GTN. He lived in sheltered accommodation alone. As I say, he was an ex-smoker. It wouldn't surprise you in the context of what's been happening. You may have noticed there's been a virus going around that actually he very quickly into the admission came back as SARS-CoV-2 positive on the basis of a nasopharyngeal swab. And we see here actually an X-ray, I think, on admission or shortly after admission, which shows the permanent pacemaker. And for those not used to looking at X-rays, we'd expect to see a bit more blackness of the air in the lungs. And we see these sort of white patchy changes, particularly towards potentially the periphery of the lungs here, which is very typical of COVID pneumonitis, the inflammation in the lungs caused by the virus. And indeed, he was hypoxic on 3 litres of oxygen. He was over-breathing, his CO2 was low. He was just about maintaining his PO2. On examination on admission, he was a bit dry, mildly confused, a bit breathing a bit fast, as I mentioned, and he had some crackles in the right side of his chest, and probably also the COVID had also caused a little bit of bronchospasm with some mild wheeze. His blood tests at that stage didn't look too bad. He had a bit of a CRP rise, a slight troponin rise, which again we see quite often in COVID patients and won't necessarily be indicative of serious cardiac damage, and a D-dimer, which is fibrin degradation products, and probably represents some microvascular changes. He was pyrexial, and before he'd been put on oxygen, he was desaturated, although at this stage not septic, and his blood pressure and heart rate were okay. So it was thought he probably had mild delirium as well as COVID pneumonitis. Because he was oxygen requiring, and I'll come on to this in a little while, he therefore was started on dexamethasone, 6 milligrams daily, as well as some nebulized bronchodilators, some fluids, and of course the principal thing that we end up treating COVID with, which is just the oxygen. Unfortunately, Mr. EP did deteriorate quite rapidly over the course of the first few days. And again, that's what we have our experience of COVID-19. He became quite pyrexial, and you can see on the observation chart here, which I've just taken a screenshot from our electronic observations, quite a high fever up to the mid 38.5, quite tachycardic with that, started to become hypotensive. So he was showing signs of sepsis. And it's often difficult to know whether there's bacterial superadded infection or this is just actually the vasoactive process that goes with worsening COVID. He also had increasing oxygen requirements. And for those of you that are used to seeing this, you can see that he was up to 15 litres of oxygen and still only maintaining saturations of 91%. This is pretty much an extremis. We can see on the left his chest radiograph is looking significantly worse. We've got many more patchy changes on the X-ray. And for one reason or another, he went on to have cross-sectional imaging with this CT. And again, we'd expect this to see mostly sort of black aerated areas, and instead we see these vast ground glass appearances and pleural changes that are typical of quite severe COVID. So we would say remdesivir to the rescue. Now, remdesivir was tested in the adaptive COVID-19 treatment trial, the ACTT1 trial. Remdesivir had already shown to have some action against both MERS, the respiratory virus, Middle Eastern virus, as well as SARS-CoV-1. And so it seemed like a good candidate for treatment here. And indeed, this inhibitor of the viral RNA-dependent polymerase against the virus was shown in the ACT trial to be effective. An initial dose of 200 milligrams, followed by 100 milligrams for up to 10 days. And the original inclusion criteria for the trial were hospitalized patients with pneumonia requiring oxygen but not ventilated, and they had to have normal renal function and normal liver function. And certainly, and anybody that's looked at this trial in detail will know that there's probably a sweet spot, as I called it at the agency when we were talking about this drug, where we're actually getting in when people have probably got viral replication, they've got worsening pneumonitis, they've got increasing oxygen requirements. And indeed, that's where the clinical commissioning policy currently in NHS England sits. And we can just see here, I've forgotten to put those on the Kaplan-Meier plots, that actually the overall recovery rates we can see was better on remdesivir compared to placebo, but that's particularly in those receiving oxygen. If they're already ventilated or they're not requiring oxygen, we didn't see that same spread of the curves, and so it clearly points towards this sweet spot. So what happened to this gentleman on my ward? Well, you can see that he was on dexamethasone for a few days, and I'm sorry, I've just stolen the blood test flow sheet result to be able to demonstrate this. And then the remdesivir was started there in late October. As is the requirement for every, he had a pretty stormy course, by the way, and his oxygen requirements had slightly decreased. But actually we see from a baseline ALT, which was still quite high with the normal range up to about 50. So it was 2.5 times the upper limit of normal, deteriorated. And so we had to stop the remdesivir, and I got a bit nervous, and we were still looking at his results, because the stopping rules for remdesivir require us to stop when the transaminases release go up to 5 times the upper limit of normal. And this is quite important because actually, of course, remdesivir, even in the original trial, had shown some non-serious adverse drug reactions, including decreasing renal function, potentially decreasing lymphocyte count, respiratory failure, and hyperglycemia. Not all of them thought to be drug-related. But one of the important things as part of the trial and subsequently in clinical commissioning is that renal and liver function should be monitored carefully. And remdes should be discontinued, as I say, if there's a transaminitis, so there's evidence potentially of incipient sort of hepatitis with the ALT going up to 5 times the upper limit of normal, or if it's elevated with other signs of liver inflammation, or, for example, a change in the bilirubin or the clotting profile. And again, certainly if there was any new renal impairment. So I think he'd had a few days of, as you can see, of remdesivir, and it seemed not unreasonable to stop. And this was when we weren't routinely reviewing, I suppose, things at 5 days. I mean, he'd certainly had that. And these days, the clinical commissioning policy would suggest that actually it's very rare that we should continue beyond 5 days. So if we use DOTS to have a look at this, of course, there's a single dose pathology here, although probably, I suspect, remdesivir, like many other drugs, will have a dose-related effect. And the time course, instead of being immediate, is this sort of intermediate period during treatment. And again, if you want to go and have a look, you can have a look at the BMJ paper where in DOTS it talks about different sort of time courses. But I would class this as intermediate. But in this gentleman's case, I suppose I may have predicted that things would have got worse. Partly because, of course, although he had a bit of prior liver disease, as you could see, he had a mildly raised transaminases at beginning, but he was obviously certainly liking his alcohol, and his chronic alcohol intake would have maybe made him more susceptible. And so, actually, I think it's really important for us to try and think about DOTS and think about these classification, because it helps us potentially predict what might go on. I won't go into too much detail, but actually it's been reported that that remdesivir may also, because it's extruded from hepatocytes by P-glycoprotein, one of the efflux transporters, is that if we've got P-glycoprotein inhibitors, such as chloroquine or amiodarone, is that they may also be responsible. And there's a few cases in this, in here, this infectious disease record around this. So, so he stopped the drug. Just a little bit about drug-induced liver injury. Of course, actually pretty common. You could give a whole lecture, if not a whole day's worth of lectures, just about DILI, as it's called. And there are obviously many experts in drug-induced liver injury. And a myriad of drugs in practice, as well as herbal remedies. Black cohosh, I think, was one of the ones that was common in this regard, can cause drug-induced liver injury. And it's probably through some of production of reactive metabolites, as we see, for example, in paracetamol overdose with NABQI, which cause covalent binding to proteins on liver cells, and through stress activation, probably reactive oxygen species release causes the damage that we see. And sometimes, like in paracetamol overdose, this can cause a sort of lethal necrosis. But in other cases, maybe again through things like genetic susceptibility, it may cause sort of idiosyncratic drug-induced liver injury. And there are a variety of clinical and pathological phenotypes about how drug-induced liver injury occur in practice. Idiosyncratic hepatotoxicity can be quite severe and is probably the most common cause of acute liver failure. So what happens to our patient? Well, after a month in hospital, he was discharged to a rehabilitation bed for intensive occupational therapy and physiotherapy input. His LFTs nearly normalized, probably back to their baseline level, and he was not oxygen requirement, although he was still mildly confused. And again, whether this is part of long COVID, who knows? But of course, this patient was very lucky to survive, and certainly many people like him I've seen, unfortunately, demise when they get to that really severe stage of COVID pneumonitis. And before I forget, of course, we filled in a yellow card. So moving on to the second case history. This is a slightly different demographic, a younger woman, a woman who was in a professional class, Asian in origin, with a history of type 2 diabetes, treated with metformin and empagliflozin, and also hypertension with ramipril. And those of you that have watched the list, of course, be very well aware of some of the issues with, for example, potentially predilection to worsening COVID in patients on certain drugs, such as ACE inhibitors. This particular patient was admitted with fever and vomiting. They live with their family. As I say, they were particularly independent and in a professional job. On examination, when she came in, she was a bit dry, a bit tachypneic again, and had some abdominal tenderness associated with her nausea and vomiting. She had a mild CRP rise and quite a high urea, and she was dehydrated, but with a fairly normal creatinine. She was pyrexial, saturation seemed to be okay, and her blood pressure and heart rate were holding. Interestingly, her blood sugar was a little bit high, but she was quite acidotic, with principally a metabolic acidosis with a low bicarbonate, a low pH at 7.2, with 7.35 to 7.45 being normal, a slightly high lactate, but certainly very high blood ketone levels. And she was treated for potentially diabetic ketoacidosis, with people potentially scratching their heads about why the glucose wasn't as high as it was. Something that, of course, actually subsequently the consultant on the post-take thought might be euglycemic ketoacidosis, but with some superadded lactic acidosis, possibly because of poor perfusion and gastroenteritis. So the patient went on to a fixed and then a variable rate insulin infusion when the blood sugars had returned to within the normal range. She was given fluids, and we paused some of her regular medicines, with, of course, not forgetting to do the always occurring COVID swab. Now, I found this quite useful, and in fact, we published this in some guidance early on in COVID. We're seeing many people with diabetes coming into hospital, as I'll come on to in a while, with potentially harms. And these are the DAM glucose drugs, or the diabetes medicines to stop when temporarily unwell. And of course, we've perhaps all seen in the past people that come in on the sort of maybe even what's called the triple whammy of diuretics, such as furosemide, an ACE inhibitor, and maybe a non-steroidal anti-inflammatory drug, causing potentially harm from acute kidney injury, electrolyte imbalance. Other drugs that should be stopped when temporarily not well, metformin, I'll come back to that in a second. The GLP-1 analogues such as exenatide, liraglutide, I've put there injectable, but of course now we've got liraglutide, which is available orally as well. And the sodium glucose transporter inhibitors, the flozins, like empagliflozin, the drug that the patient was on. And very importantly, the SGLT2 inhibitors, which of course cause glycosuria, they basically inhibit that glucose in place of sodium in the distal tubule, and therefore cause the loss of glucose. So they've been associated with, for example, candida infections in the urine and other urinary tract infections. But importantly, over the last few years, first published back in 2013, I think it was, when cases of diabetic ketoacidosis had been reported in patients taking SGLT2 inhibitors. Rarely is the blood glucose were only moderately elevated in some of these patients, which really does represent an atypical presentation for DKA, where we'd expect usually the glucose to be well in excess of 15 millimoles per litre, if not greater. And of course, this causes a diagnostic conundrum and can delay diagnosis and treatment. And here you can see the drug safety update on the left of the screen from 2016, where there was updated advice about the risk of DKA and the need to test for raised ketones in patients with ketoacidosis, even with near normal blood glucose. But earlier this year, actually, and partly because of early, I think, COVID experiences, is that it reminded people to monitor ketones during surgical procedures or acute serious medical illnesses. And so we've certainly seen this in our experience, not only in this case, but in other cases of developing euglycemic ketoacidosis on gliflozins when they develop COVID-19 disease. The other thing I mentioned, this patient had a slightly high lactate, and you always wonder whether this is just because of hypoperfusion. But of course, this patient was also on metformin, the biguanine drug, an antidiuretic drug. And it's a rare adverse drug reaction of metformin, thought to be actually only maybe half a dozen per 1,000 cases in practice. But we know that metformin can inhibit mitochondrial cellular respiration, interfering with pyruvate kinase and leading to therefore increasing anaerobic metabolism and therefore production of lactate. Whilst this can occur as a sort of idiosyncratic event when in people taking metformin, as I say, that's pretty rare. But a secondary event such as sepsis or hypotension is typically necessary for causing metformin-associated lactic acidosis. Renal impairment is again a susceptibility factor, of course, for developing this, partly because metformin may accumulate, as well as the effects on the metabolism, and therefore that's why metformin is contraindicated in moderate severe renal impairment. And this patient didn't quite, but actually had a high urea. They were slightly dehydrated. They were susceptible. But what we've also seen, of course, is, as I pointed out from the damn glucose drugs, is that there are many drugs that can cause harm that are given for diabetes. And many of these are through, for example, acute kidney injury. I found a very useful website here, thinkKidneys.nhs.uk, gives good advice on this. And AKI, I think, has become one of the new kids on the block and really important in many acute hospitals. And of course, one of the many reasons why our primary care colleagues may worry about patients in the community when they're poorly, because they may or may not know whether the patient has acute kidney injury. And this is associated with significant mortality per year in the NHS. Many of the cases of AKI are preventable, potentially between a third and a half, if one reads the reports. And there's a particular, again, focus on susceptibility drugs, such as contrast media, when people maybe get a CT scan with iodinated contrast media, ACE inhibitors, diuretics and NSAIDs, the triple whammy, as I said, and also, of course, angiotensin receptor blockers, which are acting in a similar way. And again, there's been a focus on COVID-19 and acute kidney injuries occurring in hospital because, again, the coronavirus and COVID-19 disease seems to put people more at susceptibility, partly potentially through both the maybe the microthrombotic changes as well as the myriad of pathophysiological changes associated with the coronavirus infection causing the immune-mediated storm, which again is another risk factor for AKI. So what happened? Well, it wouldn't surprise you, I did say there were COVID cases, that actually this patient had a near patient test, again, as we're now doing. So rapid PCR on a nasopharyngeal swab showed that she was positive to this. And unfortunately, just to add insult to injury, she was fairly poorly with the ketoacidosis. She became more breathless, her stats started to drop. She developed quite bad crackles on her chest. And at various points, she was on oxygen. We can see the temperature going up and down here, a tachycardia and a desaturation. So a decision was made to now start dexamethasone. It was partly made actually also because I don't want you to think that every patient that enters the QE gets a CT scan, slightly true in a way, but this patient actually, their abdominal pain failed to settle. And we were quite worried by a peritonitic abdomen at one point. And so the patient went on, and luckily, of course, the CT of the abdomen showed the base of the lungs. And here again, you can see a little bit more blackness, but certainly we can see these ground glass opacities and consolidation with even a little bit of fluid building up in both sides of the lungs, which, because of this is being taken on the patient's back, you can see is the dependent whiteness at the bottom of the thoracic cage there on both sides. So dexamethasone, as I say, was started, and where did this come from? Well, in fact, it's been in some way one of our more successful drugs, and it was shown, of course, in the platform recovery trial that it lowered 28-day mortality in ventilated or oxygenated patients. And the report, again, published in the New England Journal of Medicine. So we've been indicating dexamethasone for COVID-19 patients with any sort of oxygen requirement. As an anti-inflammatory, of course, steroids will reduce the inflammation and the severity of the acute lung injury. There were exclusions, of course, in the trial, as there always are. Uncontrolled diabetes, delirium, malignancy, immunosuppression, or any other conditions in which corticosteroids might have harmful effects. But in some ways, it would also, again, it's the difference between real world and the world of clinical trials, because this may, of course, include many of our sort of patients. And indeed, we haven't always, even if you've got somebody with slightly poorly controlled diabetes, it wouldn't necessarily stop us if we thought this patient might benefit from dexamethasone in real life. Unfortunately, by this stage, the patient was back onto long-acting insulin because they'd started eating and drinking. But of course, not surprisingly, the blood glucose control on corticosteroids went off. And luckily, of course, we were then a bit paranoid the patient might go back into ketoacidosis. She didn't, but actually it made the blood glucose difficult to control. So when we try and think about the dots here, for corticosteroid-induced hyperglycemia, I think perhaps people, not everybody, would recognize that dexamethasone 6 milligrams, it seems a relatively small dose, but actually it may be as much as equivalent to as much as 40 milligrams of prednisolone, which even in short courses we know can cause hyperglycemia. This is an intermediate reaction. It doesn't occur necessarily early in the first 24 hours, but will occur perhaps a couple of days into therapy, partly because of the effects of corticosteroids on, of course, gluconeogenesis and glycogenolysis, but actually will also can persist a day or two after stopping the steroids, which can make particularly monitoring and difficult in clinical practice, particularly when the patients go home and we've started maybe new treatments. This lady had pre-existing diabetes. She had a degree of obesity, but even we've seen quite a lot of corticosteroid-induced hyperglycemia in people with perhaps just impaired glucose tolerance. So with mediocre rises in glycosylated hemoglobin, but not to diagnose diabetes, but there. It's also seen in people with a family history of diabetes and polycystic ovarian syndrome. So there are lots of risk factors, of course, for this. And actually, we found dealing with corticosteroid-induced hyperglycemia quite tricky at times, but now have found a fairly good protocol, often with intermediate-acting insulin being given for patients with severe hyperglycemia for the duration of treatment and persisting usually for the first 24 to 48 hours after cessation of dexamethasone because of the as it were, the early late effect. Corticosteroids, of course, have a myriad again of both effects. They're fairly pleomorphic in terms of their treatment effects, and so it's not surprising that they have lots of other ADRs. And you can see them here, and people will be aware of them. Of course, things such as, of course, causing Cushing syndrome if they're given in long periods of time, and osteoporosis and myopathy. But in the short term, that we're often giving this relatively high dose corticosteroids, we have seen some problems, particularly with, for example, gastritis and sometimes causing GI bleeding. And we have seen also some neuropsychiatric effects, particularly insomnia. We should always try and make sure that we give the dexamethasone early in the day. But again, in people with maybe predilection through, for example, bipolar disorder, it can cause a degree of hypomania, and in some it can cause depression. patient actually he still had a fairly stormy course for a young woman, but after 2 weeks in hospital, she was discharged. We decided actually to discharge her because of probably poorly controlled diabetes, and particularly, of course, with the ketoacidosis on long-term insulin. And she should avoid gliflozins, the SGLT2 inhibitors, probably forever, because there would be potentially a risk of her getting it again, although this was probably the context of the acute illness that caused it. So as I say, on V-Day, wouldn't go without talking about vaccines and adverse drug reactions. And I think when the licensing committee, the Commission of Human Medicines, of which I'm a member, licensed the vaccine last week, one, it was probably the first time that many people had ever heard of the MHRA as it was lauded around the news. But two, it gives us great hope that actually that some of the cases I've just seen may be a thing of the past, with, of course, access to a vaccine. Now, when we think about vaccination in general, actually, I suppose from the point of view of yellow cards, this gives us some relative time for being hopeful that we may get some more yellow card reports. Of course, we don't want anybody to suffer from adverse drug reactions, but we know that in the past, whenever there's been a new vaccination campaign, and for example, in this paper from Dan Hallcutt and colleagues, when the Neisseria meningitidis group C vaccine was produced, we saw a great hike in ADR reporting, particularly amongst the kids. And you can see, again, the data on the slide. So it's not surprising that, of course, the MHRA and the yellow card centres have put their heads together to try and think about how we can promote, of course, yellow card reporting in the period of the COVID-19 vaccine or vaccines. Now, I know there's been a lot of, maybe you might say, concern about the accelerated development timelines, but certainly it's been through the same sort of rigorous, albeit accelerated view about the quality, safety and efficacy at the MHRA, who were one of the first regulators, of course, around the world to approve the vaccine. And goes with that is actually a fairly robust pharmacovigilance and active surveillance strategy deployed to ensure the safety. And there's a recent article in Drug Safety that talks about some of the requirements for this. And importantly, of course, we need near real-time monitoring of products, particularly for rare adverse drug reactions. And I'll come on towards the end about how important, as it were, this is. Maybe only a few thousand people receiving treatment in trials versus maybe tens of thousands, hundreds of thousands, or of course millions we hope that may receive the COVID-19 vaccination over the next 6 months. The most common vaccine ADRs in general, this is not specific to the COVID-19 vaccine, are firstly injection site reactions, and anybody that's been vaccinated will be aware of that. But other well-recognized reactions, such as fever, headaches, muscle aches, and fatigues, often go as potentially, of course, your body is putting out a small immune response to, in this case, the RNA vaccine. Less common adverse reactions may be mild allergic type reactions, and serious allergic reactions are fortunately very rare. The MHRA are going to do something more, and this is what quite often we do when we want a bit more active surveillance, is to try and have a new sort of monitoring program. So a random selection of vaccinees from certain cohorts will be selected, and these may be, for example, that may be on some immunosuppression or other demographics that will be voluntarily invited for regular follow-up. And this helps us further characterize the safety profile in a more proactive way than a reactive way of getting yellow cards in spontaneously. And again, if you haven't seen it, and although actually, as far as probably we're concerned, it doesn't matter how a yellow card comes in, if it's related to a medicine or the vaccine, then it's better to go to the dedicated coronavirus yellow card reporting site. And you can see this on yellowcard.gov.uk. It will take you up to either the traditional or the new coronavirus portal for adverse drug reaction reporting. So talking of reporting, of course, most of you will be aware that the yellow card scheme has been around for since the early 60s. And it was a response to the thalidomide disaster and the phocomelia that was caused by thalidomide at that stage, that following an initial sort of view and a committee that was set up, that actually the yellow card came out. It's secure, it's spontaneous, and it relies on suspicions only. And of course, as I'll come on to, provides early warning of possible adverse drug reactions from real-world data. And this is really important. It's the spontaneous reporting scheme, such as the yellow card system, which is used actually not just in this country but around the world, is the main system for pharmacovigilance. And reports, of course, are analysed to try and detect where new signals are coming up, although we understand that there is often significant underreporting. And I'd like to say some people have said, you know, reporting is probably only 10% of ADRs. I suspect it's much less than that. As I mentioned, you can do it at yellowcard.mhra.gov.uk. Some people still will find it at the back of a BNF if they can find that, but increasingly using the app can be useful, which is also a good source for other information. The app's available from both Google Play and the Apple stores. What to report? Well, of course, serious reactions to any established drugs, even if they're well recognized. And these are some definitions of seriousness for most people. You know, unless it's, I certainly think, resulting in or prolonging hospitalization, I often have to remind our junior doctors why they should be reporting, even maybe what they might think are mild or moderate ADRs, because actually they become serious because they often prolong hospitalization. And it's about the suspicion. You don't have to prove causality. That's for others to do. Black triangle drugs, and many, of course, the vaccine will be black triangle, remdesivir is black triangle, are the intensively monitored drugs. So either those that are newly marketed or those that have new indications. And that we would want people to report all black triangle drugs. Why? Because it's just important. We should be doing it. We need this information to build up information for patient safety, and not just of new drugs, but as I say, old drugs as well that may be serious. And this is really important. And as I was coming back to susceptibility factors, actually it's some of those little nuances, those special patient groups that we may not understand. And as we gradually get to know a little bit more about systems sort of biology, about how maybe, for example, drug interactions or comorbidities or other factors might be affecting the susceptibility to ADRs. This is a slide I was going to talk about. So if you think about anything, whether you talk about the remdesivir trial or, of course, the vaccine trial, is yes, they would have gone through clinical trials and obtained a marketing authorization and standards that occur in there. But it's really important. Pharmacovigilance is part of post-authorization safety. So even when we're authorized, we need to know. And this is maybe because only a few thousand people may have been part of trials. And as I say, many more will be part of ongoing treatment and maybe even post-authorization safety studies, such as are in phase 4 trials. And this is part of active pharmacovigilance. So the MHRA relies on the signals that are generated through your reporting, and those signals then undergo further investigation. Also, of course, they're reacting to new clinical studies and scientific literature all the time, and these often come up to the national committees so that we look at them alongside, of course, the yellow card reports, and we try and triangulate that data to see what's going on. And so, for example, in the vaccines, we'll be looking at the vaccine monitor, the spontaneous reports, and any new information from, for example, the longer term studies, as well as any new scientific literature to provide proactive pharmacovigilance and surveillance of the vaccine. The signals generally are assessed to see if the drug was the cause, as I said before, and I'm not going to go into detail about signal detection. Again, there's whole lectures on that, and I'm certainly no expert. But just to give you an idea, this is a type of ratio that could be used. So if you look at the study drug and then that specific reaction compared to that studied drug and all other reactions and all other drugs and that specific reaction or other reactions, we can, of course, work out an odds ratio of that report, that signal. here the reporting odds ratio. But there are many more advanced statistical techniques than just doing a simple box plot here that are in use, of course, both at the MHRA and in other pharmacovigilance agencies around the world. So as I wind up, you may be pleased to know is that actually this is what our rates look like, and in the West Midlands, of course, we have a yellow card centre, and we always like to be competitive against our colleagues in Wales and Scotland and Northwest and Northeast to try and have a look at what our reports are. Reporting generally has been down during the COVID pandemic. I think people have had their eyes on other information, but luckily things have picked up again in the last couple of months, and we feel relatively confident that through your actions and the actions of both healthcare professionals and of course patients, as I showed patient reporting here, and how that's actually developed not just recently, but over the past sort of 10 years or so, how that's gradually increasing. And we should be able to be very honest with our patients and try and make sure that they also understand that they can report adverse reactions. The last couple of slides, I showed this on the last webinar, so I will go through this at speed, but actually just to say System 1 has recently introduced the yellow card embedded within the system. So if you're working in general practice with the System 1, then when actually your recorded drug hypersensitivity for that patient, so this is when, for example, a drug is stopped, then it will ask you whether you want to report on a yellow card. Hopefully, therefore, it can preempt some of the data that you need, but you do need reported details, the outcome and the side effects. But as I say, some of this is pre-populated. And we hope that because many of our West Midlands practices are involved in System 1, again, that this will enhance the reporting rates that we have here. The yellow card is served as a record attachment to the patient record within System 1. So I'd encourage you to go out and explore that, or if you're a pharmacist, work with your colleagues. And as Karen put in the chat, of course, we're only mentioning System 1 because it was already in EMIS, but this is relatively new. So yes, please do, if you've got yellow cards in your electronic patient records, then please use them wherever you can. So in summary, of course, adverse drug reactions are common, and they're common in COVID-19 treatment, just as they are in many other treatments too. Vaccine surveillance is going to be really high priority in the UK, and generally I'd encourage you to report, because we know that underreporting of ADRs in general remains a significant issue. So as ever, our mantra is if in doubt, write one out. Thank you very much. As I say, we're happy to have the questions or comments part of this chat, or there's my email, or you can search for us at Yellow Card Centre or West Midlands Centre for ADRs and send in a question there. And I'm sure you've all got Christopher's, Anton's email address. So I will stop sharing my slides and see whether anybody's got any questions. And thank you very much again for your attention.
Thank you very much, Jamie, for a very informative and bang up to date discussion on ADRs. As I said at the beginning, if anyone has any questions, please put them in the chat. One thing that came to me was you mentioned the importance of electronic systems and making it easy to report. An MPharm study we've been carrying out in the hospital showed that lots of adverse reactions had been noted in the system, but because the system couldn't automatically populate a yellow card, they weren't sent to the MHRA. So integration is very important.
Absolutely. Any other questions? There is actually something there, and I don't know the answer to the question that is the System 1 integration only in primary care or also in prisons and hospital systems? I don't know about prisons. I know there's been a lot of work with, for example, Cerner Millennium to ensure that there's some yellow card integration there. And I have to say that in my own local system, we haven't had the same view of this. I'm reassured actually, and the MHRA of course don't stand still, is that they continue to do lots of work to try and make sure that, as it were, that the portals for reporting are easy to get at and can be easily connected to to all different systems. So we continue to remain hopeful that soon our electronic patient record, in our trust at least, will be able to send direct yellow cards to the MHRA. Any other thoughts, or anybody, if they want to say anything in the last couple of minutes? I'm sure that Christopher can unmute you. I think you're all automatically muted, but if anybody wanted to sing out, tell us and we will unmute you. So a question from James Milner, which I'm hoping that actually, of course, we've got colleagues actually from the vigilance system at the MHRA there. So do we have a preference on reporting method? So yes, online reporting certainly is pretty important. And in fact, of course, it makes life a lot easier. What I think we need is to get much more smart at reporting, so that when you and this is what's coming in some of the developments that's been done through the yellow card system nationally, is to actually try and have contingent questions, so that of course actually it's almost asking you smart questions when you start to report, as we see on many other websites, and that will be coming hopefully soon. I don't think it'll be here before Christmas, but soon. Will there be any extra yellow card promoting for the rollout of the vaccine at the hubs? Yes, I very much hope so. And in fact, but it's actually out to you if you're involved, because there's so many hubs, and of course it's being done at speed to actually try and get the distribution out there, is that we hope that any pharmacists, nurses and other practitioners who are involved in vaccine delivery will of course be keen on trying to promote any ADR reporting. I'm liking this. People are answering all the questions in the chat box. So before we finish, and I hand back over to Christopher just to perhaps say the last piece, I think webinar airing at screens, but actually we're very keen at the Yellow Card Centre West Midlands, the West Midlands Centre, is to be able to deliver information about general medication matters, particularly drug safety, of course related to adverse drug reactions. But we're always happy to come out to speak to groups of people if we're allowed to, with social distancing. We're very happy to host more webinars. So please, again, do let us know if you think there are particular topics that you'd like us to cover, and we'd be delighted to do so. As I say, I'll pass back to Christopher, but in the meantime, I hope everybody does stay safe, get your vaccine if you're eligible to it soon, and if it's not too early to say, happy Christmas, and we look forward to 2021. Probably my last thing should always be, if in doubt, write one out. We look forward to yellow cards coming in left, right and centre. Thank you very much.
Thank you, Jamie. Even if you've stolen exactly the line I was going to say, indeed, if in doubt, fill one out. And as Mittel has said in the chat, in these days, please fill one out electronically. It's far easier for you and it's far easier for the MHRA. Thank you, everyone who's taken part and listened and watched this lunchtime. As Jamie said, there's a feedback form. Please let us know if there are topics you'd like us to cover. And thank everybody, and goodbye.